Thank you all for coming and joining us for our lunch symposium today. We're excited to be here and kicking off this amazing Sanibel symposium with our lunch symposium today. Our lunch symposium is about choosing the right ECMO system. It is a privilege to be here today. My name is Nitasha Joyner. I am the Senior Medical Education and Training Program Manager for Medtronic, a 17-year perfusionist myself. And I'm super excited to welcome our speakers today. We have Natasha Crain that is joining us from the University of Kentucky Healthcare, and she's the ECMO Operations Manager, as well as Jamie Gordon, who is joining us from CCS as the National Director of ECLS. So we're excited to have them share their experience with ECMO, as well as talk to us a little bit more about what they look for in an ECMO system and future ECMO systems, what are ideal and what things should we consider. So thank you all for joining us today. And without further ado, I will welcome Natasha Crain to the stage.
All right, thank you all. Like Natasha said, I am Natasha Crain. I am the ECMO Operations Manager at the University of Kentucky in Lexington, Kentucky. So I wanted to start off with a little bit. No? Oh, okay, sorry. So this first picture of this little heart up here, I came across a few months ago cleaning out documents at my parents' house. This was a picture I drew in 4th grade. That was a few months after my grandfather had passed away from heart disease, and back then I knew I wanted to be a nurse. I wanted to make him feel better, make people like him feel better. And that kind of projected me through nursing school into my nursing career, where I started as a trauma progressive nurse, and then went through all the realms of cardiac care that you could. I was in the clinic, I was in the cath lab, I was on a telemetry floor, and then I went into the ICU. And about 7 years ago is when I first learned what ECMO was. And instantly I fell in love with the acuity of the patients that we took care of. And in that time, I was able to kind of learn what the body could sustain with the support of all these devices that were out there for our patients. That kind of then pushed me into becoming an ECMO specialist, which seemed like one of the elite jobs within our system. If you could be a nurse and become an ECMO specialist, you had made it. You were seen as this professional who could do anything. And I started in the heart of COVID. My first day as an ECMO specialist, I think we put 2 patients on and did 3 bedside oxygenator exchanges. And I was hooked. The adrenaline, the taking care of the patients, running back and forth, managing their care, I loved every minute of it. And within that, during COVID, my husband and I might have got a little bored because we popped out 2 babies in a year. And aside from that, I was thinking, okay, I love ECMO, I love what I'm doing, but how am I going to get home to my babies every night? And within that thought, at that time, UK came up with this ECMO operations manager position, which I was able to apply for and was blessed to receive. And in that, I started about a year and a half ago. And I have said yes to absolutely every opportunity that has come my way to look at program growth and really immerse myself in the ECMO culture and in the world of ELSO and everything. And it's kind of led me here today. So a little bit about the University of Kentucky, where I've been for the last 7 years. It is a very big organization. We just assumed position of another hospital. So right now we're confined of 6 different hospitals. We're a level 1 trauma center, the only one in central and eastern Kentucky. We have a level 4 NICU. We have over 1,000 beds right now. We keep expanding and developing. And one thing about patients that we take care of in Kentucky is in the last 5 years, we have went from taking care of patients who were in the 25th percentile for acuity to now the 75th percentile for acuity. These patients we're taking care of are very sick when they get to us. Most of them live out in the holler. They are not getting regular medical care. So then when they come to us, they have all these other comorbidities aside from what's bringing them to us. We're a magnet recognized hospital. We have been a high performer in heart attack care and heart failure. And most of our patients are regional transports to us, which has ranked us top 10 nationally for the amount of transfers that we do into our health system. And that kind of takes us to our ECMO team. We have been a member of ELSO since 1994. We have been recognized as a Center of Excellence since 2014. And this past year, we were able to renew our Gold Center of Excellence Award through the ELSO committee. These people in these pictures are the heart of our team. During COVID, patient morale, staff morale was down. So our staff did anything and everything they could to get these patients motivated to make it through each and every day, whether that was dressing up like a Christmas present, parading down the halls, or creating custom playlists for patients whenever we were going and walking them through the halls, blaring Led Zeppelin and Nicki Minaj through the halls for everyone to hear so that we could just get them to take a few more steps. This picture down on the left was of a patient who we had on ECMO for 226 days at our facility, who then went on to receive a double lung transplant. And this was him coming back a few months later to thank the staff who had saved his life. It was amazing to see him come back and be as healthy as he was at that time. Over the years, we've been pretty consistent and reliable with the care that we've been able to provide with ECMO. We were primarily a VA ECMO center, and then COVID hit, and 75% of the cases we were doing was VV ECMO. And now we're kind of seeing like other centers where we're going primarily VA ECMO again. So about 75% now of our patients are VA ECMO. And with that, we've been able to maintain consistency in the care that we've developed despite the increase in the acuity of these patients that we're taking care of. We have about a 57% survival off of ECMO and about a 51% survival to discharge with these patients. And anyone who knows the acuity and the complexity of the patients that we're taking care of can understand how hard that is to maintain and to keep developing over time. We also do regional ECMO transport. So not just within our state, but in all the states surrounding us. All these little red dots just kind of show all the centers that we've been to. And we're ground transport only. So a lot of our ground transports are 3 hours one way to go and get these patients. We are a nurse-based ECMO specialist group, and we're a nurse-led ECMO transport team. We do have perfusionists and paramedics who come in and help us be part of that team to go and get these patients, but we don't send a physician out to go and get these patients. We have the capability of offering remote transfer or remote cannulations, but not something that we do quite often. Right now, we're doing about 30 transports a year. We take hundreds of consults, and the patients that we're not able to bring in through our remote transport, we'll get them to us and then cannulate at our facilities. UK Healthcare also is a transplant center and advanced heart failure center. We do on average 25 BADs and 25 heart transplants a year. And since COVID, our lung transplant numbers have skyrocketed. Last year, we did have a little lapse of surgeon coverage with our lung transplant program, but before our surgeon had left, we had done 36 lung transplants in about 5 months. So we were seeing the volume that we needed. And I think a big part of that was the use of ECMO as a bridge to lung transplant. These patients who may have not been able to make it to the lung transplant before were able to now utilize ECMO, get them more mobile, and we were seeing better outcomes in our patients after they had left. So how are we running our patients right now? I was very blessed to walk into a program that had many options for the care that we were able to provide our patients. The people before me who set this program up, were able to push the envelope with our hospital and bring in every device and keep us knowledgeable about everything. Cardio Help was our primary circuit. It has all the bells and whistles. You can read all the monitors and sensors that you want on it. And so, the Rotaflow, the Centromag, those are solid, time and tested, true machines that are going to do the care that you need to, but it's not going to give you all the values that you might want for these patients. And we know value is important to data. Value is important to seeing what's going on with these patients. So last year, before the big FDA recalls and the supply chain issues, we were able to get with Medtronic and bring the Nautilus Smart into our house. And that has completely leveled our playing field as far as what device we're using. We're able to look at the longevity and the performance of our oxygenators on any device, on any patient at any time. Our staff, now prefers using that to using maybe the cardio help at times, just because of all the values that we're getting, plus the visibility of the oxygenator. You're able to see pre, you're able to see post, you're able to detect what's going on and have full visualization of your oxygenator at the time. So now we're kind of in this point where some of these devices are going to start phasing out, and we're looking at what devices are we going to get next? How are we going to keep improving patient care, but also maybe advance a little bit with what devices we're getting for our patients? So I went to the specialist, I went to our perfusionist, I went to who's actually taking care of these patients to see what did they want. They wanted a device that had simplicity. We don't want all the extra external monitorings. We don't want cables and wires everywhere. We don't want to have to take a 5-day training course just to learn how to use and operate a machine in one day. We want some versatility. We want to know that maybe if we have to do certain component exchanges, it's not going to be a full circuit exchange, putting our patients at jeopardy, or our transplant patients needing transfusions. Longevity of the devices that we're using, performance. We want to make sure that what we're putting our patients on is going to last however long they may need it for these patients who could need a transport or a transplant. I apologize. We want external transportability. We want to know that, if we're going to go get these patients at the outside hospitals, can we get them with this device? Are we going to have to do circuit exchanges mid-route or when we get back? Knobs for turning your RPMs. That was a big one. Didn't know that was important, but it is. They don't want to push buttons to change RPMs on a patient. And then a nice, modern, clean-looking appearance. They want something that's visually pleasing to everybody. And availability of supplies. I have been blessed and fortunate that I have been able to provide ECMO care to every single patient who has needed it the last few years, without a lapse in having supplies or being able to get to something that I needed. But when we look at the future, we want to try and get a device that is going to meet all of these needs, and that is going to cater not only to the patient, but it's going to cater to the staff that is taking care of these patients. All right. I want to say thank you. Thank you to Medtronic for this opportunity. And without further ado, here's Jamie.
Short people problems, right? So I am Jamie Gordon, and I started my perfusion career at UPMC Children's Hospital of Pittsburgh. I was there for about 10 years, and that led me to becoming their lead perfusionist there. It was an awesome opportunity. We had multiple units that conducted ECMO, so we were the PICU, NICU, and the CICU. After being there for quite some time, I was recruited by Comprehensive Care Services to take over their ECLS coordinator position at West Virginia University Medicine, and I worked primarily with their adult program. This, of course, was during COVID, PTSD, right? Nobody wants to hear COVID anymore. But this was during COVID, so it made me second guess my chances of doing this opportunity, but I did it full on. It was an amazing experience. We had a great team at WVU, and I worked with awesome physicians that taught me a lot. We then added the pediatric program at WVU to our contract within CCS, so then I was able to take that over and build that program from the ground up, which was awesome as well. I then was promoted within the last year, and I currently hold the title of the National Director of ECLS Transition and Compliance. Comprehensive Care Services is a very large company, and it's very multifaceted in that it has different divisions underneath it, like perfusion, blood management, neuromonitoring, and now we have an ECMO division, which is pretty awesome for being a perfusion-based company to have a division dedicated solely to ECMO itself. So whenever I always tell people about my position, I always get I don't even know what that means. Just like us as perfusionists, whenever we tell them what we do, you always get the perfusion or percussion, and then you have to sit there and try to explain what it is. I have the same thing now with my Director of Transition and Compliance position, because it is very far few and in between that you would hear someone within a company that is dedicated to transition and compliance of programs themselves. I get the opportunity to go into new and existing accounts and work with them. So I walk in, if it's a new account, we're going to sit there and we're going to build it from the ground up, giving it that full 360-degree approach. We're going to see what systems you need, what disposables, what does your budget look like? So that was another entity that I had to learn from as far as a business perspective. So going in from being strictly clinical to now I'm looking at the business end of things and working with different teams in that area was a whole new area of learning for me. We're looking at policies and procedures, protocols. What's your staffing model going to look like? And the beauty of our division within ECMO is that we also have a national educator and we have a staffing operations component built into it as well. So when we all come together, we can actually look at a program, whether again it's new or existing, and we can transform it to be that level of success that that hospital wants it to be. As a director working nationally, I get to work with over 150 hospitals that are currently contracted within CCS, which is amazing. I get to see everything. I've worked at, clearly the university setting of hospitals, and now I'm seeing things on a more national and global level. So that's been very eye-opening and humbling in my experience. We're always used to looking at that one way of doing things. So when you have the opportunity to travel to other facilities, it's just like perfusion. We can stick it any way we want and it works the same way every time, right? You can move your tubing this way or that way, but the blood is still flowing to the patient. So there is beauty in all of it as well. We have about 152,000 hours of ECMO within our company that's been documented for monitoring in the year of 2023. And we're able to attain all of this data and information by using our clinical analytics platform known as Orem. It's amazing. And over the last year since starting this position, we've really been able to build that ECMO data collection into a more robust data collection to be comparable to that of what we see with ELSO, or maybe you have a hospital-based data collection. But we're able to utilize that with all of those 150 hospitals that we have currently under our blanket to really see what their performance looks like as far as ECMO is concerned. Just in the last year, we had 72 centers enter ECLS data into Orem, and we were able to capture a great bit of it. It's been a little bit of a challenge, I'm sure, as you know, entering ELSA data in or anything like that. Just getting them to put that data in and being able to obtain it from your EMR or paper record is always half the battle. 20 of our centers within CCS conducted 10 or more ECMOs in 2023. So that in turn makes them a very busy center, to say the least. We have 15 CCS ECMO-based coordinators, and these are staffed at our larger based facilities, which is really nice because then they can give us that feedback to allow those busier centers to grow. All 15 of those centers that do have an ECMO coordinator are ELSO members, and all 15 of them, I have to say, are working towards boosting up their ELSO Center of Excellence, which, as I'm sure some of you know, is probably the hardest process I've ever been through. Doing that at both Children's Hospital when I was in Pittsburgh and WVU for both of their programs. It's a very arduous and tedious application to fill out, and it's a very thankless component of time that you take out of your life when filling it out, as I'm sure Natasha knows as well. I have seen every system, every disposable. I have worked with the disposables where you get a box of tubing, you have to cut, figure it out, slap it together. And I've also worked with the disposables where it's already pre-made and then you put it on the system itself. I worked with roller pumps on the big S3, rolling it down the hallway and trying to keep up with it as best as I can. But I think that's the part that's very humbling when you're working with a national level of centers. I can see how everybody's utilizing each piece of equipment differently. And then I get to see their takeaway points from it, right? Whether maybe it's a cost thing, maybe it's a staffing component, maybe it's just the system themselves. Maybe it is the physician who's old school and they like going with the Centromag because it's just good old faithful. Or you have the new physician coming in who likes the new tech that's collecting all of this data. But the hospital says no because it costs a lot of money to have that data platform with it. So there are different things that I get to look at on a basis. So for the year of 2023, because we have this Orem clinical data platform, we were able to capture exactly what these centers were utilizing as far as a high scale oxygenator and system usage. Obviously, cardio help with its transport capability is one of our higher ones. It's also nice because it's easy to train on, right? Very quick priming time. You can slap it right on there and it works just as well. And then following that, we had the PD Mag, the Novolung, we have the Life Spark. So we use pretty much everything. And then obviously when it comes to disposables, you're going to see that the Nautilus actually climbed dramatically in the last year because of obvious reasons with the recall issues with McKay. But our overall demographics for 2023 have really shown us that we need to make sure that any program that we're walking into, we have the capability to support that program, whether it is, a small baby all the way up to a grown adult. So we've been working on that as well and incorporating those demographics into what type of system or disposable we're going to be supplying that hospital or giving them our opinion on for purchase. So I guess the big questions is if you're going to start a VA program, what type of system do you want to have that will bring you the most success for your program? What is it that you're looking for? So if you're going to do a VA program like these demographics show, do you want VAD capability? Do you want ECPR capability? Who's going to be staffing your ECPR if you are doing emergent ECMO? How is that going to work out for you? Is it going to be nursing based? Are you going to have perfusion oversight? So those are different things that we walk you through as we meet with your program to build it to that level of success. And if it's a VV program looking at these demographics, what type of BMI range are you going to be looking at, especially if you're going to be getting your patients up that are on VV ECMO to walk around? What type of system and disposables will you need to have that simplicity? Again, what type of staff is going to be sitting there with it? So, VV tends to be a lot longer runs, although they're a little bit more simple, a little bit more cookie cutter than your VA ECMOs. At the same time, you still need to make sure that everything is as simple as possible. I've completed over 50 invited or self-created webinars and elevated simulations, research projects, lectures, and more. I think the beauty of what we are able to provide us sitting up here to all of you is getting your feedback and understanding what you think would be the best ECLS system. We can tell you what we think, but we also want to see what your opinions are. You're the ones out on the field. You're the ones doing everything day to day to day. I'm still clinical. I'm actually sitting ECMO night shift on Sunday. So I think that's also very humbling that we can still jump in and be part of that and see what our teams need respectively and hear those voices. That's all I have.
Is it working now? Thank you both very much. It is such a pleasure to hear about the programs that you guys are running and the number of patients that you guys are taking care of. It's such incredible work, and we're so grateful for you guys to be here. You both talked quite a bit about the variety of cases and patients that you guys are taking care of. Does it change what kind of a system you're looking for and what makes a good system dependent on the patients that you're taking care of?
Yeah, this is very loud. Hi. I think it does. If you're running, like I had said, an adult-based program, you could pretty much use any system. We all know that every system has 3 basic components, right? You need a pump head, oxygenator, and heat exchanger. So you could use anything you want. But what does it look like cost-wise for your program? What does it look like patient-wise for your program? And what does it look like staffing-wise for your program? The big takeaway, I think, is simplicity, configurability, and then the performance of the system itself. So if you're having nursing staff sit that system, you want it to be as simplified as possible, because if they're taking care of the patient and the ECMO, you want to make sure that it's easy and it's quick. And sometimes systems, although they have all the bells and whistles, and we love all the bells and whistles now, it's okay to have the simplified version where it's easy to transfer that patient safely, manage them safely, and then keep it going so that you can get them off, obviously, quicker too.
I agree. I think also taking into account kind of the world we're living in, where there's such a high turnover when it comes to bedside staff. Sometimes the more bells and whistles you have, it might scare the tar out of some of these nurses out there. So maybe, some of these patients who may have a lot of more fake alarms, they'll have more alarm fatigue with these nurses. So maybe you need something that's a little bit simpler for some of these nurses to pick up on, to catch on, to know and be able to interpret what alarms are really like high priority alarms, what are low priority alarms, just to kind of help with that alarm fatigue and keep the patient safe without stressing out your nurse, and now they're going to miss something else going on with the patient.
Great, thank you. You both have talked a little bit about transport. I know a lot of the systems that are currently available are either really designed as a bedside system or as a transport system. How do you guys see that in the future? What would be ideal for a system that could transport but also be a good bedside system?
I think, one, how heavy is that system going to be to move? How long are your lines going to be? What extra monitors are going to be in the way? Like, just safety. First of all, safety. How are you going to get the patient to and from? Our patients do internal transport all the time. We walk our patients. We take them to different scans and procedures at all hours of the night. So how are we going to make sure that we can do that safely and not have to make sure that there's a surgeon at the bedside with these patients 24/7? And then when it comes to external transport, again, the same thing, something that's not going to rock and set off an alarm like your air bubble detector and shut off your circuit in the middle of your transport. And then you're having to figure out how to do that. Your patient's probably not stable. Your patient's going to, you only have so many tools and medications at your disposal in the back of an ambulance or in the back of a helicopter, and limited space. So something that's reliable for you to be able to use. And then visibility. Are you going to be able to see what's going on with your patient while you're moving, while you're walking, inside the CT scanner, inside the ambulance? Like, having a screen or something that's going to be able to move with you and kind of be a little bit more adaptable to where you're going and what you're doing with your patients.
Yeah, I couldn't agree more. I can't tell you how many times as a perfusionist doing a transport, that clench factor really sets in right from the get-go, right? And you have patients that sometimes move and they're going crazy, and you're standing in the CT scanner while the bed's moving all the way in and the person's on the other side of the window, and you're like, don't push it in too much further, we're going to lose it. So I think having that ability, like, with any system where you can put it on the scanner or you can carry it, because clearly I work out, but that you can carry it, move it with ease. You're not really dependent upon your supply bag being full with a whole nother system. It's all together there with a portable motor as well. I think those are all very important factors, just like Natasha said.
Awesome. Thank you. Jamie, you can keep it because we'll ask you the next one. The next one is related to a variety of different clinicians that are taking care of these patients. So I know Natasha's program is mostly nurse-based bedside, but I'm assuming with all the centers that you're seeing, does that change how you do training and education, as well as what systems you might choose for some of the hospitals, whether it's university setting versus, a small outside hospital? Who's taking care of those patients?
No, but it does. I think whatever system you choose, so if you're bringing in a new system, you have to make sure that the education platform that the company provides is there to take care of your staff. So when I was a coordinator at WVU, we brought in the Novolung system. It's great. They had a phenomenal education team that stuck with our specialist team, who's RN and RN at WVU, the entire way. If they had a call at 1:00 in the morning, they responded. I know with other systems, we do have a lot of trouble getting a hold of some folks, which is understandable because, like Natasha said, we have a lot of turnover going on in ECMO perfusion world lately, and a lot of system issues. But I think that any system you bring in, you need to make sure that the training is easy, it's simplified. Again, you're keeping it streamlined across the board. So if you're doing yearly competencies, quarterly wet labs, you're bringing that company's education team in so that they can do the competency practice on their own checklist format. I think those are incredibly important to keep your team safe, because if it is a small program and they only do 3 or 5 ECMOs a year, that team needs to be educated more so often so that they do know how to respond to alarms like Natasha was talking about. Whereas the busier centers that are doing 50, 60 ECMOs a year, they're very familiar with it. And then you have the capability, like Natasha's program, to have multiple ECLS systems. But for the slower programs, probably just one where you have a dedicated team that can back it and be as supportive to that department as possible.
Awesome. Thank you. And then another question relating to that is, do you think that more information is better for people or not necessarily? Do you think that different individuals need different amounts of information, or do you think you should keep it consistent across the board?
I think everybody trains differently. It's just like, learning in school. Are you a visual person? Do you have to write things down? So that's half the battle with being in any of our leadership positions, is giving your team all of the tools that they need for success. So if I have to work with someone a little bit more or have the company come out and work with them more, then that's what we're going to do to provide them those tools for success. You never want to set someone up for failure. It's just like a new grad coming in from perfusion school or RN or RT starting out as a specialist. If they are geared and they want it, then they'll make it happen for them, just like we all did and why we're all sitting here. So I think that getting to know them and what they do need is very important. And picking that system or disposable and getting that support from the company is huge. That's like, I don't know, that's the cream to my crop.
I agree. I think the training's the biggest aspect, like Jamie said. As long as you have provided the training, the company's there to support. Your nurses, your perfusionists, your physicians are going to put faith in the device that they have been given to be able to take care of these patients. Everyone may like something a little bit more than other, but we all have those one-off times where something malfunctions and we hate that device. We don't ever want to see that in our hospital, on our patients ever again. But in all reality, every patient is different. Every patient's going to come in with something different. Like there's, an oxygenator out there that is fabulous for the pediatric world, but in my opinion, it's not good for the adult world, just because adults probably have more fat in their blood. They have more stuff in their blood that's going to clog up these oxygenators. But I think just the training and the familiarity with it, you can adapt to anything as long as you have faith in what you've been taught and your ability to use that device.
Awesome. Thank you very much. Along those lines, companies that get approval for ECMO or get the indication to do ECMO, they're able to actually do training and education on their devices. Do you think that is beneficial to centers such as yours, or how do you see industry's role in the ECMO space?
I believe it is beneficial. The first thing whenever you take a new device to your upper administration or to your legal team, they're going to look at, okay, what is it cleared for? What are we protected by? What is the indications of it? And then reimbursement wise as well, like just looking at the not so pretty side of it, the ethical, the legal side of it. Yes, having support, having, a regulating facility come in or organization come in and say, yes, this is used for this, it's indicated for this, and it's safe to use for your patients, definitely helps when it comes to what device we're going to purchase next, because we know the testing that they went through, all the trials that they went to prove the efficiency of these devices.
So I'm like old school. Whenever we first started perfusion and everything was off label, right? There was no FDA approval for perfusion, cannulas, equipment, systems, heater, coolers. That's always a big one. So now that we are seeing a lot more equipment coming out that is FDA approved, I think it's amazing. Just like Natasha had said, from a legal stance and seeing how important it really is that we are getting these FDA cleared. But it is definitely a new experience for us older generation perfusion staff, because it's a lot harder to get systems into hospitals now, because now they want to see that stamp of approval, which is lovely. We might think it's great and say, no, just bring it in. We're good. We work with off-label stuff all the time. But I think it's actually better now that we are seeing the FDA approval like everyone else.
Awesome. I appreciate both of you guys taking the time to talk with us. I think we'll open things up to the audience. Again, like Natasha and Jamie said, we're here to also make sure that we're meeting the needs of each of you as well, and making sure that the new systems that are going to be coming out to the market are beneficial to you. So we will open it up to the audience if anyone has any questions for Jamie or Natasha.
Hey, ladies. It's loud. Thanks for a good talk. I have a question really more about what makes a good ECMO system and everything. What do you guys think about some of these new systems that are coming out with a little bit of automation built into it? With staffing issues, different technologies, there's a lot of disruptive ideas and, globally about what ECMO should be from a machine perspective, dealing with, different training aspects and stuff like this, because a lot of these things are thought to be automatable. How do you think that's going to impact training and then selecting your systems?
I think that it's easy for us to think that anything's autopilot, so the training's still an important component looking at any system for the troubleshooting aspect of it. So I could walk away even from my pump in the OR or my pump at the bedside, but do I know how to troubleshoot it quickly enough and get there in time to still keep my patient in safe quarters? I think that's why a lot of people are moving towards the RN staffing model, where the RN and RT staffing model, because they're very familiar with being at bedside more often. So they're already there and they can just walk away and then run back in a pinch, but just making sure that you do have all of that training provided for the troubleshooting component, so that when the alarm fatigue, like we had discussed, is really there, we know which alarm we're listening to or sounding to. It's kind of like the Nautilus Smart, because they have the light colors, which is really nice. So COVID, when we were locked outside the room, you saw the orange light, the green light, the red light. So that was very helpful because it wasn't a sounding alarm like she had alluded to. That does get annoying. I know you guys all love that CentraMag alarm. So things like that can help with that autopilot, like you're saying, I think are really important.
I agree. I think, sorry, this one was a little loud. I think the troubleshooting is the biggest aspect. How many times have we had, a certain system loose flow because the bubble detector went off, and you walk in and you see someone hand cranking when they shouldn't be hand cranking, or doing something inappropriate? The training is going to hit it. Yes, a device can run itself, and your ECMO patient may be the most stable patient on the unit until something goes wrong. You can walk away from that patient 12 hours out of the day, but then you come back and all, has broke loose. And now you're having to figure out, okay, is it my device that's wrong, or is it my patient that's wrong? And what should we be doing, and how do we take care of that to ensure that we're still protecting this device that's going to keep them alive, but also not causing more harm to them?
We got a couple online questions. First one being from Judy Buchman, saying, what are you replacing your rotoflows with once they age out?
That is to be determined. Okay. We are honestly looking at everything out on the market right now. Cost is a huge, huge aspect to that with any hospital, any university who's state-owned. They want to see the numbers. They want to see the proof, the longevity of everything. But then also taking it back to the bedside, what does my staff want? Am I willing to fight for something that's a little bit more expensive that I think is going to provide better care to my patients and make life a little bit easier on my specialists? Yes. We do 110 to 130 ECMOs a year in one unit at UK. And I have 10 specialists who run all of those ECMOs. So they're going to get tired. They're going to be the ones who are taking care of these patients day in and day out. So I want to make sure that whatever device I'm going to provide them, it's something that they're going to be happy with, and something that they're going to be, happy to come in to take care of. Not something that they dread, like walk in the room and they're like, crap, this staying on CMAG is going to alarm all night. I'm going to have to come in here, all that kind of stuff. Things that are going to really cater to the staff, plus, be proficient and take care of the patients the way that they were designed to take care of the patients.
Next question we have is from Danielle Ney, saying, one of the many selling points of Nautilus is no clotting in the corners. Did you find this to be true?
I believe so. We've been using Nautilus Smart for about a year now. We have not seen any issues in clotting. We have, like with our VA patients, these patients usually are hypercoagulable. They're going to have more bleeding issues, and some of them are not going to be able to be on anticoagulants during a period of time. Being a level 1 trauma center, we have trauma patients who come in with head bleeds and things like that, and they're not able to be on anticoagulants. And we have seen them last on the Nautilus devices longer than maybe some other devices where patients were on anticoagulants at that time and therapeutic. So I do believe that, what we have been told and what we have been shown in the data of the trials with that device has definitely proven itself to our patient population.
The next question is from Leela Bovidico. For how long can we keep the Cardio Help set primed? And if you have any data that can confirm how long we can keep an unprimed and primed circuit.
So also registry, they just put out new guidelines. I think it was like maybe 3 or 4 years ago, where it can go past 30 days. My recommendation would be to go talk to your infection control department, as well as including your physician, and see what they have. I know that at a lot of centers within CCS, we're doing 60 days. But again, that's up to your infection control. So how are you building it? How are you priming it? Are you keeping it in a temperature controlled environment? So there's a lot of things along those lines that you need to inspect and make sure that your infection control department approves of it, as well as your physician. But it's obviously under the hospital's discretion, and also just provides guidelines for the direction you can take that to.
The last question we have is from Kevin McCusser, saying, a strong triad leadership best serves the need for rapid program implementation. Experienced physician leadership and champions who are experts in ECMO, nursing leadership, and hospital executives. Are there other important components we may be missing?
So anytime I think of an ECMO program, I look at the entire hospital, not just the higher ups, from the housekeepers all the way to bedside nurses, RTs, PTOT. All of them play a huge role in how we take care of these patients, right? Typically, housekeepers become the closest with the families because they're in there talking to them as they're cleaning. So they might know things that we don't even know as clinicians because they just have that different etiquette or comfortability with the staff. So, you can always go, we always want to go to the higher ups, right? Because we want the more toys and we want to make sure that we stay on their good side. But at the same time, it takes that whole entire hospital to keep that patient and that family happy throughout their entire ECMO run. So whenever I go through a list or I go through our guidelines, I make sure that I include PT and OT for education and because we want to move these patients. So what do they think would work best? How can we train them to help them? Nutrition, we want to get the gut moving. So maybe there's something there that we can work with them. Pharmacy's a big one. I include pharmacy on all policies and procedures at each hospital so that they're part of that anticoagulation protocol that we're setting. Blood bank, we're using so much blood products whenever we're putting patients on ECMO and throughout their run. They should definitely be a part of that whole process as well because it's expensive using that. And is there different things that we can change to make it easier? I don't know if you have anything more past that.
I don't. I think that was wonderful.
Thank you.
Thank you all for participating today, and thank you both very much. It was a pleasure to learn from you guys, and you guys have such great expertise. We look forward to talking with each of you more about what you guys think makes a good ECMO system. So thank you for joining us today, and enjoy the rest of a phenomenal Sanibel Symposium. Thank you.
Thank you.